Hello, and thank you everybody for joining us for today's webinar. I'm Mandi Berg.
I'm Carey Mead.
And today we are going to be talking about data and what is it telling you and how to be a data detective. Okay, so Carey, talking about today's subject, what are some of the top trends and schemes that you find useful when you're looking at data?
Probably the biggest that's hitting me right now in the plan I'm in is the impossible days, impossible hours, the ridiculous blowing of edits that far exceed what the appropriate MUEs might be, what normal units are possible within a day. There is so many plans that don't have the proper editing in, or have not designated a proper policy with limits associated, so that providers have realized that most have vulnerabilities, and that is prevalent within the data.
Absolutely.
Yeah.
Yeah. And it's one of those things that it's not hard to put an edit in place. Like a lot of plans or providers in general think that it's very, very difficult to do. It's actually not as difficult as you think. It's just a matter of working with your vendor,
Right.
your program, and putting them in place. And it's really key to stopping the money from going out the door. You know as well as I do that basically pay and chase is harder than
Yes.
stopping it from the front end. So I completely agree with you. Claim edits are super important. So for those of you that aren't familiar, NCCI, MUE, National Correct Coding Initiative, medically unlikely edits. For those of you that aren't familiar with what those abbreviations are. So a lot of things that you talk about when doing edits or even looking at data in general, right?
Right.
The first thing that we start at, or at least what I do when I'm looking at the data, is as a whole, what is the story telling you, right? I always like to look at my provider and what are the top codes that the provider is billing you? What are they billing together? Because just like you mentioned, like NCCI edits, if you don't have edits in place, that's a great place to start, right? What are they billing together on the same data service? And then if you do have edits in place, a common thing that the providers can do to get around them are modifiers. Modifiers are always a game changer for those kind of system edits that they put into place. Um, what are your other thoughts or that you see kind of happen with those?
Well, the modifiers, a lot of times, again, plans are missing those system edits that would be there had that modifier not been present. But most of the time, with the splitting of claims, that splitting of claims behavior that you see demonstrated in the data, a lot of times can be a really big red flag. Additionally, when you're looking at spikes in billing over the course of a year, 2, 3 years, you're looking to see, did they just begin billing a particular code? Did they evolve into a different way of doing it so that they're now getting paid for additional services that are questionable within their plan, within their category group? The questions is in behavioral health, there are so many out there that are practicing with unlicensed staff. And when you see things like impossible hours under a particular MPI, we know that it's likely that they're sharing that information and having numerous people bill underneath them. That is a huge consideration and something to be mindful of. Additionally, the splitting of claims is one thing that I see predominantly as well. When you start really drilling down into the data and you're seeing them intentionally split those dates of service out to bypass any potential editing as well, or that people don't think that when they see that is a concern because it's not on the same data service, but that does demonstrate an intentional act of bypass.
Yeah, those are really great red flags to bring to everybody's attention. And you're right, like those are very common schemes, especially like with laboratories, the splitting of claims data. That is done very frequently to bypass NCCI edits. Additionally, you're going to see that with I have seen it a lot with physical therapy codes as well. They're going to split those, or even chiropractic services. they're going to split those. So I like that you brought that up. What I have also noticed recently is there are a lot of codes that AMA CPT has actually changed to. Before they were like bilateral codes, and now they're like a unilateral code. The description has changed. What the providers are now still doing is they're billing the code twice, and they're using a left and right modifier to separate them on the claim so that they're still getting paid twice, when in actuality, they should only get paid once. And that modifier is allowing them to essentially get that extra service for that extra payment when they shouldn't. Um, why is it that the systems are allowing? I mean, in your experience, is it the modifiers that allow that bypass? I mean, that's what I have seen historically, that those modifiers basically set off a trigger that say, hey, this is here, go ahead and pay me. Is that something similar that you have seen as well?
Right. The modifiers, especially the 25 and 59 that are automatic bypass modifiers, those are systematically going to bypass the edits that would have previously protected you as the provider or the plan. When they're using those are intentional acts that are chosen to bypass to obtain additional payments. The problem is, does the documentation support this? Additionally, in DME, for example, when we've seen recently an example of they were getting paid right, left, and another right, or they were using the 50 modifier on what you have already identified as now a unilateral code. So there's different ways to look at it. And what it is it's just needs to be a very vigilant effort on system editing. That should be something you're looking at every quarter at minimum. When something's identified, you need to start having those dollars identified, that how much could potentially be overpaid. Urinary catheters is a heavy hitter right now. I'm seeing examples of where 900 units a month are being paid when we should only be looking at approximately 200 per month. And that is with appropriate documentation of actually reaching out to the patient for instead of auto shipping. But at minimum, there's so much opportunity to quantify those results and roll them into your ROI so that you can justify the costs of making those system adjustments.
See, I love it. Like, these are areas where data mining and diving into your data are extremely helpful. So just like you mentioned with bringing into like the urinary catheters, incontinence supplies, depending on the state, well, I mean, not even depending on the state, but for an incontinence supply, if you do not have a diagnosis associated with incontinence, these supplies are not considered a covered service with Medicaid and Medicare. That's one of the first places that you should be checking. Do your diagnosis codes support these? And if not, then these services should not be paid. We actually have found in a lot of instances that there are completely non-approved diagnoses being written for these services, and they're getting through. So that's also a really great place to look at. Is your diagnosis appropriate for the services that are being rendered? Because in a lot of instances, that's a really easy way to kind of like data mine out as well.
For Medicare policies, for example, you can read through that policy and know exactly what system editing took place if you read it thoroughly and carefully. Anytime a diagnosis is mentioned, guaranteed that's a system limitation within that's being edited in. Additionally, if there's frequency references or if there's coding, bundling notations, those things are automatically going to be edits placed in the system at the time the policy is implemented. So as soon as a policy is reviewed and rendered by a plan, it should also follow as well. So that if you have excessive services deemed at X, Y, and Z per month or per day, that is already edited in at that time. That way you can be sure that those things are being updated proficiently.
I love that. So that's why it's always very important to know your plan, know your policy, know what you're looking at. I love that. I love that you're bringing that up 100%, because depending on if you're looking at CMS, if you're looking at commercial, it's all going to vary. But It's going to come down to know your data, know your plan, know your policy, and then furthermore, what is the documentation going to show as well? I love too that you're talking about auto shipment because that is something that we see a lot of right now. Uh, so with Medicare and Medicaid, you cannot auto ship, and it is happening all of the time right now. So if you wouldn't mind, could you just kind of explain what you're looking for when you see a case that has auto ship for those of us that aren't familiar with it, maybe?
So when I'm looking through the data, I am seeing a repetitive interval of monthly supplies always being sent to the patient. Sometimes they exceed the amounts, but typically I'm seeing it stagnant. It's always the same amount every single month. Sometimes in the data, you'll also see that patient could have had an inpatient overlap. There could have been other skilled nursing facility stays that took place, breaks in service that were identified through other data. That can be something you can see to help break it down. So, Mandy, what else do you look for?
Yeah, so same situation, right? You're going to look for, just like you stated, overnight stays, being in a skilled facility, being in inpatient rehab. I'm going to look where the quantities aren't changing ever, or where they will literally order maybe 150 and then 2 weeks later they order another 150 and they literally do the same thing every month for years on end, especially if they're constantly exceeding what the monthly limit is. That's also a red flag to me, too. So, depending on what state you're in, there is a monthly limit. Uh, if they're always exceeding that, why? Why are they exceeding it? And do you really think that they need to exceed it? And then, additionally, like if these members are going to maybe a senior adult daycare during the day, or maybe they're doing something else during the day, and you look at their individual data. If they're at these other facilities, are they actually going to be home to utilize all of these supplies or not? So those also kind of come into play.
Right. Just your claims history alone might demonstrate some of those other breaks in service that wouldn't have warranted them to use the same amount of supplies that month. You can't have that overlap. It's prohibited. Practice is to call the patient always, and it's required to verify checking how many are on hand, but also a best practice is requiring that documentation to be at least within 1 year. And there needs to be a documented notation as to the utilization within the records that explains why this month we needed 30 more supplies than we did last month, or 100 more supplies. There could have been some reason for it, or change in medical need that warranted those changes, but you can see it glaringly obvious in the data.
Absolutely. So, some other things besides like DME supplies or things like that, you had mentioned kind of like impossible days, but even scenarios like psychotherapy. There are a lot of instances now where we're coming into psychotherapy where it actually turns out that what's actually being done is group therapy. But when we get the medical records, they're billing us for individual therapy, but the notes actually reflect group therapy. What are great ways to kind of do a data dive and find that? I know one of the things that I have done historically is look at, do you have family members that are in common, or what does the provider website state? I had a provider case where she clearly listed that these 2 different dates a week were nothing but group therapy. And we would literally ask for records for those days. And that's actually when she billed everybody as individual, but that's not what everything was advertised as. And that's not what the records showed.
Right. So some of those examples that come to mind recently, when you're looking at their websites and you're seeing their hours and you're seeing that they're not an inpatient type of situation, watching them bill over holidays like Christmas or Thanksgiving is usually a good indicator too, that there's just a routine billing going on. What I've been seeing a lot lately is those incredible units being billed per patient, per distinct member. That's one first indicator, and then you start looking at what they're doing, and sometimes now they're incorporating psychotherapy in addition, where this this provider is literally billing 18 hours a day. And there is no way that anyone in a group setting would be withstanding that level of therapy. Even for autistic kids, a 10-hour day is too entirely long, but we see it routinely. So we know that either they have potentially somebody unlicensed or they're billing for services not rendered.
Absolutely. 10 hours is hard for an adult. I cannot even imagine for a child to sit that long. A school day is a long day for a child.
Mm-hmm.
So for somebody that is autistic, that just seems very unlikely, even with breaks. So that is great, especially I like how you mentioned like the impossible days and calculating kind of like the time that goes along with them. So I noticed that one of the things that we have been seeing a lot of is you had mentioned earlier, kind of like NPI misuse. So when you have providers that are billing these impossible days, uh, what is it that you're finding? Is it like the PAs that are doing services, nurse practitioners? Can you kind of walk through how it is that you're calculating the days, or what it is that you do with the data dive?
Right. So in the behavioral health example, there's a good way to take your distinct members based on your distinct actual units that we allowed. And when you break that down, you start seeing a pattern over a period of time, and actually, quite frankly, an evolution that yields a spike in billing that shows that they began to do this particular pattern at this time. And what we're seeing is they're alleging they're doing incident to services by having someone sign off, but the individual rendering the care is certainly not licensed anywhere to be performing it. But additionally, the incident to criteria is not met. A signature alone doesn't justify that billing. So in more doctors' offices, you're going to see the PA probably doing some services. And in some cases, if the incident to requirements are actually met, which is extremely rare, then it makes more sense. But if we don't have the incident to criteria being followed, then it becomes a credit back for the services that potentially would have been rendered if coverable for that PA. Where in behavioral health, if they're unlicensed and they weren't appropriate in the first place, that is an entirely uncovered service.
Absolutely. So in that instance, there's no credit and no payment that could be made whatsoever.
Nope.
Yep.
And the plans are very, very vulnerable to those things at this point, because there's mental health parities to be considered. We want to make sure that these individuals have access to the care they need or the resources they're looking for, but there cannot be misappropriation with their care either. The quality of it and the actual plan of care, their actual progression of care, their goals, their different treatments need to be demonstrated in the records, and 99% of the time we're not seeing that adequately done.
Absolutely. All very important information, not just in looking at the data, but then also when you get the records, making sure that you're reviewing all of that and that your auditors are clearly documenting and finding all of that information. Yeah. So thus far, we've reviewed talking about like what are your providers' top codes? What do they typically build together? Are they splitting claims? Appropriate diagnosis, use of modifiers, AMA CPT, NCCIs, and MUEs. We've also talked about like impossible days. One of the other things that I know that we do kind of as background research, right? We look, does your provider hold a valid license? Doing a simple Google search of the address. Those are kind of like key pieces of information looking with the data. One of the current things, like with laboratory cases, one of the biggest problems that I have found in doing just general research, there have been many instances where these facilities either have their validation has expired, or they don't have the level of validation that they have to have for the services that they are allegedly rendering. Or my personal favorite is the address is completely bogus. Those are super fun. What other kind of unique instances have you found with some of these kind of like data research, data diving provider cases?
There's so much opportunity to even just evaluate patient clustering. That is a huge thing within hospice care. They tend to recruit and they get patients or multiple patients at the same location involved. Home health, personal care assistants, those kinds of entities, especially if we're dealing with a potential kickback scheme where the patients are being paid a certain amount of dollars or handed gift cards or some sort of gift, that does become a big red flag. There's a huge uh, amount of providers out there who are clustering numerous patients. Most of those people don't even realize they've been placed on hospice. So imagine how uncomfortable those interviews are when you need to call and speak and ask them if they're on hospice and they have no idea what for.
Wow.
So those are very difficult, especially calling the parent of a minor and asking them to verify this, that their child has been enrolled in some sort of a hospice scheme. So it's definitely something glaringly obvious in the data, and the death rates alone should be the first thing that you look at, whether or not this is a viable hospice or not.
That's a really good point. Um, so I love that, right? Shared address locations. And then obviously, just like you mentioned with the hospice cases, how long have they been on hospice? So your cases typically will not last longer than 6 months because that is the expectancy, 6 months or less. So if you have somebody that has been on for greater than that, why? Great question.
Mhm. There's schemes out there where we evaluate the death rate of the hospice provider. And if it isn't up in the 80s, 90s%, there's something wrong. Then they're enrolling people that should not be put into that level of care at this point. Diagnosis obviously drives, but does the patient's condition actually warrant it?
Wow.
So,
That's a really, really good thought and great data mining. Absolutely.
yeah, so I mean, we think largely ambulance, transports to nowhere. One of my favorite things, they're transporting to nowhere. That at the end of the day, are they getting to and from? Does there seem to be appropriate care once they're at their destination? Does all of that line up? And those are the things that we tend to evaluate just first glance in the documentation to see that there's just cause to look forward.
Absolutely. And the same would go with like the DRG kind of cases, right? The most common scheme right now are the sepsis cases. If you have a sepsis case and you've been in the hospital for less than typically 4 days, mm, something something is probably not accurate. Those should be evaluated and reviewed because if you are septic, you are shutting down. There are a lot of things that are happening. So the question is, does the data essentially show everything to support that you had a lot of services done? Did you have um, essentially, do the services really match up what they build, your diagnosis, that kind of thing, or was something lesser going on? So
Mhm.
there's a lot of opportunity in data. Uh, So
Yes.
absolutely.
Yeah, and DRG is a very popular item currently where a lot of the plans are evaluating their internal auditing. They're looking to see, what are they looking at within their claims history? What does the patient show evidence of any of these complex diagnoses? For in septic patients, do they have some organ failure? Do they have, the proper diagnoses? For the pneumonia patients, is all of that warranted? And those are the things that we're all looking for to and then if you have chronic offenders, are we monitoring them closely enough?
Absolutely. So, some good scenarios that we could essentially give the audience out there to kind of like start data mining on, right? Your E&Ms that have 25 modifier use all of the time. That's kind of a good place to start. It shouldn't be a common denominator in your data, it should be kind of like one offs. Um,
Mm.
your oh my goodness, my brain just totally stopped. Your DME items that
Yep.
are considered unilateral, where they're using the right and left modifiers to break them up, those kind of scenarios. Your potential impossible days. So the psychotherapy codes, the ABA therapy. I know we talked about DME items, so your NCCI and MUE edits. So like the CAF services that you were talking about, anything that is greater than the 200 units in a month. Any other big opportunities that you think we're kind of missing? Like senior adult daycare services are very, very big right now.
They're huge. They're huge. Does the building have the capacity to hold as many patients as they're billing? We've seen that time and time again.
Oh my goodness. Yeah, there have been some very interesting cases with those senior adult daycare centers. You're right? Just doing a simple search on those as well. A lot of these facilities are very, very tiny, and the number of people that they bill for just to one plan alone in a single date is alarming. And then when you consider that they bill to multiple plans, there's no way that they can house as many people as they are billing for. So it is quite interesting when you take that into consideration.
Are their locations even handicap accessible? Do they have the capacity, or are they running a nightclub in the basement, which we have seen?
We have seen, absolutely. It is never ending, and it actually makes the job enjoyable sometimes when you can see like this just one-off interesting stuff, because where there is a will, there is a way.
Right. And the other thing to consider too, have you identified patient sharing? Have you followed the patient IDs and looked to see who all's been billing them? Right. If you see continuity in the adult daycares, there's a possibility that there's a kickback scheme or worse happening. So usually there's marketers involved, and when you see that patient grouping go from one place to the next, it may not be just in one category. It could be a personal care situation along with an adult daycare where they're sharing the lists and all taking a little piece of the pie, and then pretty soon you'll see DME also engage, and that speaks highly of a marketer who's arranging these relationships and potentially giving kickbacks.
100%. Who are the common denominators? Who are the common doctors, the practitioners, the facilities, all of that? Follow the money. Yep. Absolutely.
For sure.
Well, as always, if you guys have any questions, do not hesitate to put them in there so we can answer them. And don't forget that we do have monthly webinars, so we are always excited to have you guys join us. Thank you for joining us today, and we look forward to seeing you in November.
Thank you.